Hi everybody, 6202 students. So when we had our meeting last night, I had really bad issues with the internet going down. So what I'm going to do is go through and just play this game by myself. Wish I had someone to play with, but hey. So here we go. I'm on the site now, which you should see, but I just wanted to show you for those that have not been in here yet. I highly encourage everybody to go in here because I develop the questions and really make sure that there's a lot of content that you guys need to know that are in these questions. So, all right. If you see the screen here, this is right when you type in the username and password. Make sure you put a capital J because I do have two accounts, and the other one with the lowercase j only has like a couple games in it from a long time ago. So this is the active one. And once you get in here, you can see all my games here, but it's easier if you just click on Adults 2, 6202, and then all the games are here and you can see. And I even put some math calculations in here so you can play around with that because you will have some calculations on your final exam. All right, so I have Burns and then I have ortho. What I recommend is going through Burns and ortho, and then you can just review the other ones because you know it's a cumulative exam. All right, so I'm going to start a new game. Okay, so we're going to start on Burns. So the first question is, increased permeability of the capillaries can cause what? Right, so now we're thinking burns, right? So what's going on with the patient that they have increased permeability of the capillaries? So usually that happens during the emergent stage of burns and dehydration. So if you go back to your slides, but here's another slide here, which you could see if you go in there and practice that it's a little bit bigger that you can tell. But during the emergent resuscitative phase, that's where you just have a severe burn and you're doing fluid resuscitation. You're doing it, maybe you're out on the scene, or maybe they just got to the ER. So that's your ABCs, your initial wound care, injury management, because you want to prevent shock, or you want to treat if they're already in shock. So that's with your management of fluid loss. That's when you're going to do your calculation and determine that you're going to give half the dose within 8 hours and the other half over 16 hours. Then you have your acute intermediate phase, and this is when people start to diurese and have more, they're not in shock anymore. Things are starting to balance out. Homeostasis. So this is maintenance of your respiratory circulatory status, fluid and electrolyte balance, and GI function, infection prevention, wound care, pain management, nutrition. So this stuff is very important. So just remember, we have the emergent, and then you go into the acute when everything's stable and you're just doing treatments, and the others are rehab. So when we go through these questions, really everything stems around what phase are these people in that have these burns, and determining how we're going to treat patients. All right, and also most likely, if you have a severe burn, it's going to be they're going to be transferred to a burn unit. You never know where you're going to be in your career, though, and so I would definitely make sure you know this, especially if you work in an emergency acute care setting, because you can get anything and everything in those situations. So next question, what's the best indicator of fluid status? So we could definitely say that, we can make sure their vital signs are stable, of course, but really the best indicator and easiest is urine output. We want to make sure that what's going in is coming out adequately. Are they getting enough fluids or are they not getting enough fluids? Okay, so sorry, it went back to the other. So as far as urine output, yes, that's the best indicator. Remember, it should be at least 30 cc's an hour. So if you're finding that this burn patient is not bringing out enough urine, then that is an indicator that this patient needs more fluids. So remember, dehydration, they have a lot of fluid loss from all the open wounds that they have, as well as physiologic changes that are going on in the body. Okay, now this is a calculation, so I want you to go through this and do the calculation. It's pretty easy because it's already out there for you. Here it says fluid replacement, the total body surface area, percent times the weight in kilograms times 4 ml. So this is going to help you figure out what you're going to give as far as fluids. And perhaps you could have something like this on your exam. So you don't have to memorize the calculation here, but just understand how you're going to calculate it, know how to do it. So 80 kilograms, 20% burn. So you would do 20% times your 80 kilograms times 4 ml. That's going to give you a number of 6,400. If you divide that by 2, it's 3,200 because you want to give 3,200 over the next 8 hours. And then you're going to give the other half over the next 16 hours. The Parkland formula. Okay, so what are the types of burns? And what I was looking for, what are types of burns? Sorry, I've got notes that are in front of me also. Okay, types of burns, which I'll go the answer. Whoop, I guess I didn't write it. But, so we have superficial burns. We have superficial partial thickness burns. We have full thickness burns. Deep partial thickness burns. So there's all different types of burns. Things used to be easier, first, second, and degree burns, which is I'm kind of still in that mindset of being second degree burn. But really it makes more sense because you can have what used to be called a second degree burn, but there's varying degrees of that. So are you going through the part of all the dermal layer, or just part of the dermal layer, or just doing the surface of the dermal layer? Because if it's superficial, you know, it's burning the epidermis. Once you start going to that dermal layer, then it becomes more of either a superficial partial thickness burn or deep partial thickness. Once it gets full thickness, you know you're going down to the bone, and that's a dangerous situation. And then, as the answer says, how will you prevent infections? So infections, they have all of these open wounds, and so we always have to think, open wound, we have to be on high alert for preventing infections. They could be healthy as can be, but we still are no comorbidities, but they still are at high risk for infections because now they're vulnerable because they have so many open areas. So how are you going to prevent infections? You're going to do reverse isolation. That's the most important thing you could do is to prevent infections, is reverse isolation. Everybody should wear gloves, gowns, face masks. So you need to follow the reverse isolation precautions. Family can still visit, but they just need to follow the rules. Okay, great. So let's talk about CURLINGS ulcers here. What are CURLINGS ulcers? This is specifically for burns. So it's a gastric erosion. It's acute. It's a complication from severe burns. So what happens is you have a reduced plasma volume. If you have a reduced plasma volume, it can lead to ischemia and cell necrosis. So it sloughs the gastric mucosa. So it starts eroding away. And so the goal is to prevent this. So you prevent it by giving them proton pump inhibitors or H2 blockers, including ranitidine, Pepsid is another one. So it's really important to do prevention in that way. Okay. And also with this, remember with these patients, if you're having gastric erosion, what's going to happen? You can start having bleeding, right? Because it's no different than getting a scrape or a cut on the outside of your body. Is this happening on the inside? So you're going to bleed. And then how are you going to know that they have possibly this erosion that needs help? Well, they're probably going to start having blood in their stool. So if you have a patient say on a burn unit, or someone, if they have blood in their stools, that is an indicator that they can have a Curling's ulcer or just another GI bleed in general somewhere else. But just make sure that you are watching for that as a nurse. Okay, so what type of burn requires immediate flushing with water? With this type of burn, that would be more of a chemical acid burns. You see this a lot. You see a lot of this at workplace occupational hazard settings. All of us should be trained on how to treat burns. It's an OSHA requirement at all organizations to go through some type of module in education. So if you get any chemical on you or acid, you want to get it off as fast as possible to prevent worsening of the situation of burns. Okay. All right, so cardiac monitoring is essential for this type of burn. Well, it's electrical because our heart is electrical, right? Conduction system, and so is a bolt of lightning, and so is putting your finger in a light socket or getting accidentally touching some electrical wire. So they are at high risk for having cardiac dysrhythmias and death from having an electrical burn. And it is kind of interesting if somebody gets hit by lightning, usually you'll see a point of entry and then a point of exit where it comes out. What is the outcome of burn patients? So what is the outcome? Now, of course, it depends on the degree of or the percentage of burn. So you can use the rule of nines to determine that. And but if people have third and second degree burns, they may not be functioning as they did prior. But you probably don't want to tell the patient, well, you're not going to get to how you were before. You want to be more of like therapeutic communication and just be like, you know what, we just want you to be able to function as high capacity as you can. Of course, we want to reach the goal of functioning before, but remember, if they have second and third degree burns, especially if it's more deeper thickness in the, I'm sorry, I'm saying for second and third degree. When you think second, think partial thickness, or deep partial thickness, superficial partial thickness. Okay, when I say deep tissue, that's third degree burns. If you say superficial, plain superficial, that's more of a first degree burn. All right, so remember they have nerve damage, neuropathies. Those are all complications. So they may not be able to function like they did before, but we just have to be very careful how we talk to the patients, as well as skin may look different because they had skin grafts, continued pain, that kind of stuff. So thermal burns to the patient's airway requires what? So if you have a thermal burn due to fire, smoke inhalation, or even some people can have inhalation, chemical inhalation burns too, which happened in, I think, Winthrop Harbor or Zion, not last semester, because my daughter works in the ER at Vista, and they got a whole bunch of chemical airway burns. They inhaled it, and they had to intubate like 8 people in a row. They were all intubated because it was causing inflammation and swelling of the airway. So with these patients, anytime the airway is affected, you want to just intubate the patient because you don't know when things are going to go south, and they have some inflammation too, so you want to help with healing. So what's the difference between a superficial partial thickness and full thickness burns? So partial thickness involves the epidermis and only part of the dermis, and I know we just talked about this too. They are subdivided into superficial and deep partial thickness burns. All right. What does a full thickness burn look like? All right, so this is a picture of what a full thickness burn looks like. This obviously needs to be debrided and cleaned off, but it does turn dry, tan, hard, swollen, and because it's damaged the nerves, they really don't have pain, and it's down to the bone area usually, so they don't have pain. But this here is definitely a deep thickness burn, deep tissue burn. And how do you calculate the rule of nines? So I know this is a little picture, so you may want to go to another source. You can just Google rule of nines picture. And I would just understand what this is. I would understand where the numbers are also. So for example, this is a question, what's the percentage of burns if the patient has partial thickness? So it doesn't matter if it's full or partial, you're still going to do the same rule of nines. If it's in the groin, that's a 1%. Back of left leg and anterior chest, you're going to add those up, and that's going to be the percentage of burns that the patient has. Okay, so that is it on burns. And what I'm going to do now is go to ortho. Play ortho here. Also remember with burns, you want to watch neurovascular status. We're going to ortho, and yes, that's very important too. But with burns, you want to watch that too, because what if someone has a full thickness burn, and then all of a sudden you can't feel their pulses, or they're having increased symptoms, like all of a sudden they can't feel their fingers or their legs. So, you know, you have to just be on the alert. So any change, you want to call the provider. And we know when we're taking the exam questions, you're going to look at the choices. So most of the time, if it says airway, you know, you have to do your ABCs, but many times it's going to be notify the provider, because you can't give, like if you suspect your patient might be going into shock, you can't give more fluids without the order. So you need to call the provider first. So if that is a choice on your, always think, can I do this without an order? And if call the physician is a choice on there, you're going to choose that first. Now, in reality, do they have standing orders everywhere? Yeah, they do. So you have some autonomy. But for NCLEX reasons and safety reasons, we always have to have that in the back of our mind. Do we have an order? So which requires more prompt attention, an open radius fracture or clavicle fracture? So we had a good discussion about this last night, and it's really an open fracture. So that would be the most important, because when you think open fracture, or another name is compound fracture, there's a piece of bone probably sticking out of the skin. So now we have an open area, a lot of bleeding, increased risk of infection. So that needs to be stabilized immediately. Whereas a clavicular fracture is most likely a closed fracture. It could be open, depending on the way it breaks, but the question asked open versus closed. All right, now you're putting a cast on a patient, which actually it's kind of fun doing that. So how are you going to put a cast on a patient? Now they make fiberglass, and we talked about this last night too. I haven't seen plaster casts in a long time. Seems like it would be a pain in the butt to put a plaster cast on when they have fiberglass now. But I was saying plaster casts years ago were more, it's more fun because you can really draw really cool, nice things on there. It's a smoother surface. So, but anyways, keep a newly molded cast in your hands allows for what? The proper shape of it while it's drying, because remember it's wet and it dries fairly quick, and you want to shape it. You want to keep it in the palm of your hands. Don't use your fingers whatsoever, because we think of pressure ulcers. All right, if you break your ankle and you need a leg cast on going just below your knee, use your palms only to keep those in your hands to make sure it dries and shapes really well. You don't want to rest it on a pillow. You don't want to rest it on anything, because you don't want any pressure. So the safest thing to do is just keep it lightly as possible in the palm of your hands and let it dry that way, because you don't want skin breakdown. As it is, they already have atrophy of the muscle, dry skin that happens over time, and you don't want any redness or ulcers going on in there, skin breakdown. All right, so what's a comminuted fracture? When you think comminuted, it's multiple fragments. So it's a complete fracture across the shaft of the bone into multiple fragments. So when you think comminuted, multiple fragments, however you can try to memorize that. Now, a green stick fracture is most often occurring in with children because they fall. And this is where one side of the bone's broken and the other side is bent. So it's not completely all the way through fractured, but you have one side that's bent a little, not completely fractured through, and then the other side is broken. And now we have the compound fracture. Those are your open fractures. So there's an open wound or break in the skin near the site of the broken bone. All of these require splinting, and most require eventual casting. It just depends on where it's at. So take, for example, my husband who fractured his heel. He doesn't need a cast. He just has to be off of it for 10 weeks. He did not need surgery. Thankfully, we thought that that was going to be the case. We got there, and the surgeon said that there was only very mild displacement, although it shattered in several pieces. He said the heel is one of the worst bones to break because you can have a lifetime of disability and difficulty walking. So I'm really praying that he won't have that. He's got 2 weeks left off of it, and he's been just going around with a little wheelie. So anyways, but yet there's other fractures that do require having a full cast on to be completely immobile. All right, compartment syndrome. This is a dangerous situation. This is where you're caring for your patient with a fracture, and you need to really be watching neurovascular status and pain status. And this is caused by bleeding in the muscle. It's most often from an injury, a fracture. Bleeding starts going into the muscle, blood starts going into the muscle, and now you're having increased pressure, which can cause nerve damage because now you have a decreased blood supply in that area. So it's definitely a dangerous event. So you want to watch for that. So a patient with a cast from a fracture 24 hours ago is complaining of increased pain. Despite pain medication, what's your first action? That's going to be to call the provider because you're thinking first off in your mind, this could be a compartment syndrome. So never second guess yourself thinking, oh, I don't know if I should call the doctor. Maybe he's just not getting enough pain medication. It's better to be on the safe side than sorry, because the last thing you want is a patient to have compartment syndrome. Usually these patients just are in severe pain that won't improve. So true or false, I don't have to wait until full healing of my fracture to get my cast off. That is true. So most fractures, the casting, we really want to keep the casting on as least amount of time as possible. So it can be removed when they're strong enough for mild activity. So it doesn't have to heal all the way through. So remember, there's different phases of healing with bones. All right, Buck's traction. What's Buck's traction? Buck's traction is used for in the lower limbs, for femoral fractures, lower back aches, acetabular and hip fractures. Back in the 90s when I worked, I worked in the 2000s too on the floors, obviously, but back in the 90s, we had, oh my gosh, we had so many patients in for chronic, it's called intractable lower back pain. They would be in for 5 to 6 days with traction. So remember what traction does. It helps prevent spasms in the lower back. But now we realize that patients don't need to be in the hospital for that. If it's a hip fracture, that's completely different. So your patient requires surgery for a femur fracture. His blood pressure is 180 over 110, and to me that seems a little high, and he appears dehydrated. That's not good. So he asks you when his surgery is. So what are you going to tell him? So looking at this question, my thought is, okay, requires surgery. So we know he has to go. Femur fracture. Is this an emergency surgery? Like, does he have to go right now? Probably not. His blood pressure is 180/110. So that's high. We need to get that blood pressure down. Dehydrated. We need to give him fluids. I don't want him having general anesthesia and being dehydrated with hypertension. That's high risk for complications, a stroke, shock. So the best answer is surgery will be scheduled soon, but we are giving you some IV fluids and medication to decrease your blood pressure so you're medically stable. All right, so fat embolism. So that's different than a DVT going into a pulmonary embolism. That's a blood clot. So this is fat. And what are the causes of fat embolism? This is usually after a fracture of the long bones in the lower body, particularly your femur and your tibia is the more common than the fibula, causing a fat embolism. And what it is, it's a piece of intravascular fat. It lodges within a blood vessel and causes blockage of blood flow. Like it occurs commonly, but it's an uncommon occurrence too. But just know what a fat embolism is. So when you're caring for a patient, you always have in the back of your mind certain complications. And I cannot get this 400. There we go. Okay. And how's a tetanus shot related to ortho issues? Well, if you have an open fracture, you're at high risk for infection. So you need to make sure that you're up to date on your tetanus shot. Simple as that. What is phantom pain? So these people have had amputations for a variety of reasons. A lot of it is diabetic sores, ulcers that have not healed. That becomes ischemic, gangrene. We don't want the infection spreading, etc. Gets into the bone. So this is common pain in the area of the extremity removed. So how will you treat this? You're still going to treat the patient immediately post-op. So let's just say you have a patient that had a below-the-knee amputation on the left leg, and he is complaining of pain in his foot on that leg where it was removed. Well, it's really common because, remember, the nerves are very mysterious, and there's a lot of circuitry involved that hasn't really disconnected from the brain. And so your brain still really thinks that that extremity is still there. So immediately post-op, you still want to give opioids. You still want to give medications. Remember, they also have an incision. Over time, you're going to want to work with the patient in more of a primary care setting, pain management, that they'll be more on medications to help with nerve pain, such as gabapentin or Lyrica, as well as other types of medications, gabapentin being the most common. But that's how you're going to treat this. It's a very common occurrence. It can actually, I've seen it, heard of it happening for years afterwards. But it does end up getting a little better for most people, or better. So hip replacement patients have to limit certain movements initially. What are they? Remember, these patients, they just had their hip replaced, so you want that to heal up. Whatever material that they put in the hip to replace it, you want it to develop some healing scar tissue around the area so you don't dislodge anything. So you want to make sure you don't bend at the hips or knees further than 90 degrees. So if they drop something on the floor, they can't go pick it up. They shouldn't be crossing their legs over. Shouldn't be lifting the leg to put socks on, because again, that's flexing at greater than 90 degrees. These people get the lift for the toilet seats, so they're not bending down too much onto the toilet, because we don't want it to dislocate. All right, and what is normal capillary refill? Less than 2 to 3 seconds. There's the variance, but I just say less than 2 to 3 seconds is normal capillary refill. So this would just be a clue that when you're doing neurovascular checks, make sure you know what you're looking for. It's great to touch the toes, but know exactly the seconds. some reason this is not letting me get through to my next one. So let me go back. Yes, go back. Sorry, guys. Because I'm on my other computer, glad we don't have problems today. All right, so did we do this one yet? Yes, we did this one. Okay, let me go to this one. All right, what is skeletal traction? So skeletal traction, and I put a picture here, is someone that has had like a femur fracture. There's a really good picture here that shows you what it looks like. And so with these people, remember they have an open area then, so you want to watch for signs of infection. So any greenish, yellowish, ugly drainage, increase in redness, warmth, patient has a fever. Clear drainage is completely fine coming from the site, that's normal. And then look at the weight. You want to make sure the weight is hanging. You don't want it on the ground. That's how you know that it's not working, if it's laying on the ground. And my cast is falling off. What should I do? You go get a new one. So let's talk about casting for a little bit. So initially, when someone has a fracture, you're always going to splint it, meaning perhaps a half a cast or just a really heavy dressing on the area that's fractured. Because there's so much swelling going on, you want to definitely have some room for that swelling to decrease. Otherwise, it's going to become too tight, and that can be a dangerous situation. So you're going to splint it first, and that's usually what's done in the emergency room or acute care, urgent care settings, ortho, and then you go home, you make your appointment with ortho, because usually it's the ER to ortho, and they'll say, all right, let's get you an appointment in 3-4 days. By that time, you've iced it, you've rested it and elevated it, and hopefully the swelling's pretty decreased. So then they will put a cast on, and then you'll follow up in increments to get cast replacements until the time is ready to get the cast off completely. During that entire time, you're going to make sure that you've done a lot of education with your patient to watch for increasing signs. And the patient's going to know, because if they have increased pain, they're going to definitely call the doctor. Okay, so I finished the ortho and the burn. I just want to make sure that I've touched on everything here. And it looks like it. It looks like we're good. Okay, and that's it.